All right, today we're putting on our detective hats. We're going on the trail of a really stealthy killer, an infection that can start in some surprisingly common places, but ends up launching an attack on the very engine of our bodies. We are investigating infectious endocarditis. So, how does this even happen? I mean, how can bacteria that we encounter all the time suddenly mount a full-scale siege on the heart? It's a crazy journey that can start with just a tiny breach in our defenses and spiral into a massive medical crisis. So let's follow the evidence and see where it leads. Every good investigation has to start at the crime scene, right? So first up, we're going to identify exactly where this attack happens inside the heart. And then we're going to line up the usual microbial suspects. Okay, let's be super clear. Infectious endocarditis, or IE for short, isn't just any old heart infection. It's incredibly specific. It targets the endocardium, that's the smooth inner lining of the heart chambers. And most importantly, this includes the surfaces of the heart valves, those delicate little gates that are constantly opening and closing to control blood flow with every single heartbeat. Now, you might be thinking these culprits are some rare exotic superbugs, right? Well, think again. We are talking about incredibly common bacteria. Staphylococci, the kind that often live right on our skin without causing any trouble, they're the #1 cause. And streptococci, yeah, the same bacteria that gives you strep throat, they're right behind. Get this, just these two groups alone are responsible for the vast majority of these dangerous heart infections.
Okay, so we've got our suspects, we've got our crime scene, but how in the world do they get in? How do they breach the heart's defenses? Well, it turns out the path to infection is a surprisingly methodical 4-step process.
And here is the absolute key to this whole mystery. A healthy heart lining is like a fortress. It's incredibly smooth and resistant, almost impenetrable to bacteria floating by. So for an infection to even have a chance of starting, the bacteria need a vulnerability. They need a crack in the wall, a break-in point where the defenses are already down. So this break-in happens in a few stages. First, something has to damage that smooth heart lining. This could be turbulent blood flow from a faulty valve, which is constantly scouring the lining like a river eroding its bank. The body, doing its job, rushes in to form a tiny, sterile clot, basically a little scab, to patch up the injury. But here's the problem. That little healing patch becomes the perfect hideout. So when bacteria inevitably get into the bloodstream, and this can happen from something as simple as a dental cleaning, they can find this sticky clot, latch on, and start to grow into this dangerous infected blob called a vegetation. All right, the bacteria are in, they've set up shop. Now what? Well, the body isn't just going to sit there and take it. It starts sounding the alarm. And our job as detectives is to piece together these distress signals, all the telltale clues that point to an invader setting up camp inside the heart. The #1 clue, the big flashing red light, is a fever. We're talking more than 95% of patients will have one. It's the body's universal alarm bell ringing. The only issue is it's a really non-specific clue. It just tells us, hey, there's an intruder somewhere, but it doesn't tell us where. To really pinpoint the problem, we're going to need a lot more evidence. So we've got to sort through the evidence, and it really falls into two main buckets. On one side, you have these vague systemic symptoms, fever, chills, fatigue, the kind of stuff that just makes you feel like you have a really, really bad flu. But the clues in the second bucket, they point directly to the heart. A new or a changing heart murmur is a huge red flag. It suggests a valve is being damaged. And shortness of breath, that could mean the heart's pumping action is starting to fail. Okay, this is where it gets really interesting, kind of like something out of a medical drama. Every medical student learns about these classic physical signs: Janeway lesions, Osler nodes, splinter hemorrhages. They're famous. But here's the twist. In real life, they're actually super rare. Each one shows up in less than 10% of cases. So yeah, they're fascinating, slam dunk clues when you find them, but you absolutely cannot rely on them to solve the case. So we've gathered all this evidence, the flu-like symptoms, the more specific cardiac signs. Maybe we even got lucky and found one of those rare physical clues. So how do we put it all together? How do we officially close the case and confirm our suspicions? Well, there's actually an official playbook for this. To get a definitive diagnosis, doctors use a kind of checklist called the Modified Duke criteria. The whole point of this system is that it doesn't rely on just one single clue. Instead, it's all about combining hard evidence from two key areas: what you find in the lab and what you can see on direct imaging of the heart. And really, this whole checklist boils down to finding two absolute smoking guns.
First, you need evidence in the blood. That means taking blood samples, putting them in a dish, and actually growing one of our usual suspect bacteria. You caught the culprit red-handed. Second, you need evidence on the heart. You get this with an echocardiogram. It's an ultrasound of the heart, and it lets you literally see the crime in progress, the vegetation growing on the valve. If you've got both of those, case closed.
Okay, diagnosis confirmed. Case solved. But now the real fight begins. The mission completely shifts from investigation to intervention. So how do you fight back against an infection that has literally taken root inside the engine of your body?
4 to 6 weeks. Let that sink in for a second. The cornerstone of treatment is a long, aggressive course of intravenous antibiotics. We are not talking about taking a few pills for a week. We're talking 4 to 6 weeks minimum of powerful antibiotics being pumped directly into the bloodstream to try and wipe out those deep-seated vegetations.
But, sometimes antibiotics just aren't enough. Surgery has to get involved when things get really serious. This happens if the valve gets so destroyed that the heart starts to fail, or if the infection is just too stubborn and won't clear. Or, really scary, if pieces of that vegetation start breaking off and traveling through the bloodstream, threatening to cause a stroke. In those cases, surgeons have to go in, physically cut out the infection and repair or even replace the damaged valve. And these numbers, wow, they really show you what's at stake here. Early detection is everything because while most patients, around 82%, do survive to leave the hospital, the long-term outlook is pretty sobering. An 18% mortality rate in the hospital is high, but the fact that up to 40% of patients might not survive a full year, that just shows you how much devastating, lasting damage this infection can cause.
So after all that detective work, we've cracked the case. And the trail leads all the way back to a pretty surprising place, our own mouths. This whole life-threatening heart condition can start with common bacteria just getting a free ride into the bloodstream during a routine dental procedure. It's a really powerful reminder, isn't it? That taking care of our teeth and gums isn't just about having a nice smile. It's actually part of defending the very heart of our health.